Welcome, everyone, and thank you for joining us this afternoon for this discussion of the Boston Globe story, The Virus's Tale. With us are two members of the team that reported and wrote this very impressive story, Neil Swidey and Evan Allen. Neil is a writer for the Globe Sunday magazine. Evan is a member of our narrative team. Also with us are two people who figure prominently in this story: Joe Ramirez, a certified nursing assistant at the Soldiers Home in Massachusetts, Holyoke, and Michael Mina, an epidemiologist at Harvard's T.H. Chan School of Public Health and director of a virology lab at Brigham and Women's Hospital. Thanks to all of you for being here. Neil, I want to start with you. This story is clearly an incredibly ambitious undertaking. And I want to know what you would say precipitated this story, and what were you and the team hoping to find out in the course of your reporting? And what would you say were the big surprises?
Thanks, Steve. I think we were sort of the proxies for the readers in this case, where we were watching this crisis unfold and trying to make sense of this riddle that didn't quite make sense, which is we're here in Boston, the hub of medicine, academic medicine, the hospitals, the universities, the research labs, the biotech companies. And if any place on the planet should have been ready to handle this pandemic when it hit, it would have been this sort of place with this surplus of resources and best and brightest minds. And so we were trying to figure out how that happened. How did we in Massachusetts kind of get behind? To what extent was that the federal problem that was just unavoidable because of all the mistakes that happened on the federal level? And to what extent were there mistakes on the state level that sort of slowed things down? And I think when we really got under the hood to try to figure out the response, we learned a lot. We learned primarily the importance of signaling. You know, that I think that when a public health crisis is emerging, you look for signals from people. Primarily in this country and around the world, the CDC has been the kind of gold standard for a place that gives you that signaling of what to take seriously and how to respond. And then it moves from there. The White House, the FDA, and other agencies on the federal level, those send their signals down to the state and regional levels and then the local levels from there. And there were so many mistakes that happened on the federal level and that blunted the power of that signaling. And then the responses on the federal level were so flawed that then by the time it got to the state, you really needed people here to be on task and ahead of schedule. And that's where we saw this kind of curious place here where Governor Baker's administration was just about a week slow in that first part of March, where we sort of saw that lost week. And that really seemed to have a negative signal to others around this whole emerging group of people who were going to respond to this.
And kind of an outsized impact at that stage of the outbreak here.
Yeah, I think so. I think we had something that happened very interestingly in Massachusetts. We were, you know, the first place on the East Coast to get a case, which was the UMass Boston student, was a confirmation on February 1st. So that was late January when that case emerged. And it kind of, the response was sort of textbook good. From the university level to the city and state level, people responded in the way with the seriousness and the kind of coordination that you would hope to happen there. And I think people, in some cases, breathed a sigh of relief after that we're going to be okay. And that was a little bit dangerous in some cases because Massachusetts got very lucky with that student. He was just so conscientious. He didn't go anywhere. He didn't go to CVS. He didn't go to the campus center. He got off the plane. He wasn't feeling well. He went right to the student health center, didn't interact with anyone else, and then stayed in his off-campus apartment quarantine for 7 weeks. And so there were no known transmissions from that case. I think there was a little bit of a false sense of security from there. And then I think when things got really serious, as we saw in the end of February, with the Biogen outbreak that that happened there, and then out in the Western Mass in the Berkshires, when you had the emergence of community spread, both those two very powerful fronts in this war were coming into view by that first week in March. And that's when the governor left for vacation. I think that signaling was in retrospect, very negative for everyone else kind of coming up to speed, because you did see other institutions in Boston, from Harvard to Mass General to the other places, kind of moving towards from peacetime to wartime footing, and yet the state was not doing that.
I want to pause just for a second. Everybody out there who's joining us, you should have a Q&A box at the bottom of your screen. We are not only encouraging, but relying on your questions. So plug them in early and often, and we'll get to them as quick as we can. Evan, I want to turn to you. The story is really two stories that are intertwined. On one hand, it's the response of the public officials that Neil was talking about in the medical and scientific world. On the other hand, it's a very personal and powerful depiction of the spread of the virus as it invades different communities and devastates individual lives. That story brings a succession of people, starting with the person you call patient zero, the first case of community transmission. His name was Rick Bua. Tell us how you came across him and the significance of that particular moment in the outbreak.
Sure. So Rick Bua was the first confirmed case of community transmission, and he got sick out in the Berkshires. And I actually set out looking for him. We knew from early March that community transmission was first identified in the Berkshires, and community transmission is a very important turning point in the evolution of a pandemic. Until you have community transmission, which is when a disease is spreading sort of silently through the community and you can't identify where a person has got it, as opposed to, you know, a UMass Boston student coming in from China, or people coming in and having contact with sick people at a Biogen conference. In those cases, you can identify the source of the virus, and then hopefully, if you move quickly enough, you can contain it to stop it from spreading. When you hit community spread or community transmission, you have lost control of the virus. You don't know where it is and you don't know where it's going. And so we knew from early March that community transmission was first identified in the Berkshires, which was sort of an unlikely place for it. I think most people were looking for community transmission in a city, in Boston. But what we wanted to do is find out, like, how did it start in the Berkshires, and why did it take so long to be acknowledged in the Berkshires? And so I talked to a whole lot of different public health officials out in the Berkshires, and eventually found a public health nurse who had done contact tracing for that first patient, and she put me in contact with him. So his name is Rick Bua, and he and his wife Debbie are just really lovely people. The thing that is so shocking about Rick's case is that, you know, this is a 66-year-old grandfather who, he's retired. He likes to spend a lot of his time sort of just on his property in Clarksburg, which is a town of about 1,700 people on the western edge of the state. He actually had just finished treatment for Hodgkin lymphoma. And so he was already doing some of the social distancing that is now what we all do, but for different reasons. So he had been to, like, the dump, a couple of local restaurants, to church, to a couple of basketball games. There was no reason that Rick Bua should have coronavirus. And in speaking with him, it became clear that, you know, he had become infected sometime in February. And when he went to the hospital, he had this doctor, Dr. Kaleko, who started to believe that he may have coronavirus, but because it was so implausible, she couldn't get anybody at the state level to listen to her and test him. So she started calling the state and asking for him to be tested. And they said, well, we're not seeing community spreads, so Rick can't have coronavirus, which is, of course, backwards. The reason they're not seeing community spread is because they're not testing Rick. But the so finding Rick and then finding Dr. Kaliko was really pivotal for our understanding of how the state was viewing what coronavirus was to Massachusetts in those early days. And the answer to that is coronavirus is not really here yet. Like, it's come in on a couple of different people traveling in, but it hasn't taken root. And the reason they thought that is because not only were they not looking for it, they were sort of actively screening it out. Dr. Kaliko called 3 times before she could get Rick approved for testing. And she described this sort of incredible moment when she had been seeing these other patients all week coming in with no history of travel and sort of the same symptoms as Rick. And when he came back positive and she realized she had to test all of these people, she said that it was like looking at an optical illusion that suddenly snaps into focus. And she said that they had all been looking for coronavirus to come into the emergency room and to announce itself in just a clearer way. Like, I have traveled and I feel sick in this way. Like, I just came from China. I know a person who's sick. Everybody was on high alert for it. They'd come up with screening questions. They're all reading all of these studies out of China and Washington. And in the meantime, their hospital is filling up all around them with people who have coronavirus, but they're not seeing it because the state is not looking for it. The state is trying not to look for it.
And that was coming, the dates, if I recall now, are the very early days of March. At the
first time that Dr. Kaliko asked to test him was March 3rd, which is also the first day that the folks over at Biogen first flagged the beginning of their cases.
This is beginning of a really critical time for the state. Now, Michael, you were seeing danger coming before that, if I'm right. Take us back in time to your perspective in January or February or whenever it was when you were beginning to see danger coming. And I wonder if you could tell us about your recollections of the warnings you were trying to sound and who was listening and who wasn't.
Yeah, so I come at it from wearing 2 hats. On the one hand, one hat is as an epidemiologist, an infectious disease epidemiologist, and then the other is from a testing perspective, where my role is to help bring tests to people at the hospital. And I can say that from our perspective, back in early January, at that point in time, and even in December, the world's epidemiologists were sort of focused on this virus. So that the question of whether the virus was a threat wasn't, at that point, it wasn't a threat. It wasn't a question, I would say, to most epidemiologists. The real question was just, when was it going to land on our doorstep? By early January, the virus demonstrated pretty well that it can transmit readily. And it had moved out of Wuhan in China into all different provinces throughout China to other countries. And so it was no longer a question of, is this going to be a virus that stops? It really, I think it started it started to become very, very clear that was going to be the case. And so we were modeling it more from afar. And I recall that I honestly can't remember exactly what week or month it even was, but I recall thinking at one point that we were so focused on the epidemiology of this virus and mathematically modeling the virus as a group at the Center for Communicable Disease Dynamics, where a number of the faculty labs are that study these things. And at some point before the Biogen conference, it became very readily apparent that this was going to be a reality for Americans as well, and we weren't going to be able to sit back and keep modeling the epidemic internationally. And that's when, I guess that was in January, because then it was the last week in January that I recall getting pretty agitated that commercial entities that normally produce tests weren't starting to move on this. There was very little direction from the federal government to start rolling out tests. And because of that, the big companies were very unclear about what they should be doing. And I recall it was sometime in the last week of January that I went into the hospital and went into the pathology director's lab. And I work part of my job is as a pathology director. So I went to my boss's office and said, we really need to get viral testing up and running, at this hospital. And before that, I was already starting to sort of sound the alarm a little bit on Twitter saying we don't have testing. And it was really obscuring from that perspective. It was obscuring our ability to see where the virus was going internationally. But we had to start acting then at the end of January if we wanted to have any chance of being able to see the virus by the time it got to our doorstep. Unfortunately, I think, it's a slightly different part of the story, but everything fell apart at that point at the national level, which filtered down to the state level in terms of testing. And testing ability was really taken away from the states, and in particular from the individual laboratories and hospitals like ours, to be able to test our constituents. And that's what led to a lot of the problems. Why people were not being able to be allowed to be tested was because there was just no capacity. By the end of February, there were still only hundreds of tests run across the US and not millions, and so we went blind into this, and we remained blind into March, and it was just an astounding fumble on our nation's part, I think.
So put this together for us. First of all, tell us why testing is important.
So it really gets to Evan's point, which is if you're not testing for a virus, you're not looking for it. This is a novel virus. So we didn't have perfect case definitions where we could say to somebody, these are your symptoms, you have this virus. With any novel virus, you have to build that picture up, and people need to get used to what a coronavirus patient might look like. But far before that, you have to start testing for it to just know that it's at your doorstep. Otherwise, viruses are invisible. In particular, a virus like this, which now we look around and we say, okay, we know that as many as 9 out of 10 people with the virus might be asymptomatic. So it can be completely, surrounding hospitals and companies and nursing homes and VAs, and you would have no idea unless you're testing. And so testing needs to be, whether that's for the virus or for antibodies or whatever it might be, you need to have eyes to see what's going on around you. Otherwise, you're sitting ducks in the dark. And that's where we found ourselves.
Joe, this ended up playing out for you in very real terms. You were a certified nursing assistant, and I believe on the memory ward there, but maybe other places at the Soldiers Home. You saw it all unfolding and ultimately got sick yourself. Wondering if you could describe for us your experience as this new illness began to creep into the home, and at what point did you realize that there was really something very wrong and very different, that this wasn't just the flu?
Steve, as I was reading the article, these the great stories that were given out, and from Michael and Neil and Evan and everybody wrote, I was just amazed at how many warning flags we had out there in the state. And looking back at it, there was a lot of warning flags within the building. But I think the biggest fail we had is that from our administration, from our top nurses and, people that we have in the Holyoke Soldiers Home, is that we didn't think to say, when is it going to get here? I don't think any of us ever thought that, this coronavirus is going to hit the building. Nobody was prepared for that. So there was a lot of warning signs from the beginning of March, that first week where a lot of the veterans were having, mild symptoms, coughs, colds, some temps, but knowingly we just got out of a whole flu epidemic in the building. So it wasn't, for us, it was like, well, maybe he's still getting over it since, that age group, holds on a little longer to sickness. in hindsight, we're thinking that virus was already in the building. It just nobody thought to say, maybe we should start testing. As you know, from when Mr. McDonald's symptoms were showing, we still didn't test, this veteran. They were still wondering what is wrong, with him. What else can we do for him, other than all the tests already done, and to finally somebody, came up with, well, let's test him. I think during that whole, when we finally heard that he was being tested, I think that's when the sounding bells came off for all the nurses and CNAs. I think that's when we finally got into, oh, it could be here. And I think a lot of people were, were cautious, worried a bit. But at the same time, our administration didn't emphasize, the importance of, if it's here, we need to react or protect ourselves or do something, because there wasn't that sense of urgency that we could get it or that it was going to spread. For that whole week that we were waiting for results on Mr. McDonald, nobody was protected. Nobody was wearing masks. Nobody was wearing gowns. As you said, staff floats up and down different floors. So as I was reading the article and obviously through the whole process, I realized that we were in contact with possibly patient 0, and we spread it out throughout the building. And even when we decided to test that veteran, administration continued to have everybody, flow freely above to other floors, to help out because we were so short-staffed to begin with. But once we found out that he was positive, everybody we kind of like froze, and we went into work mode as we do, with nurses and CNAs, and we do what we have to do for our veterans. But I think a lot of people were scared. I think once everybody found out there was a positive case, everybody was scared. Everybody was concerned. Everybody was thinking about, their family, their friends, am I going to get it? What are the symptoms? And, we all had symptoms, as one of the symptoms is you lose your sense of smell or taste. A week prior to it hitting, a lot of us were like, hey, you know what? I don't taste anything. Do you taste anything? And we didn't really have those, those basic knowledge of that. So once it hit, it was scary. But, for most of us, we don't think of ourselves or what's going to happen. We just went into this mode of, okay, well, we got to protect these veterans. We got to take care of them to the best of what we can. Once it hit, it just seemed like the week prior, the building was closed. Each day something different happened. First we closed the canteen down. Then veterans and their visitors could only visit in their units. Then no visitors, and veterans has to stay on their units. So we knew something was happening. To us, we knew administration knew something, but they weren't sharing with the rest of the direct caretakers, which is your nurses and CNAs and anybody that has, contact with our veterans. And then once it hit, I think all chaos broke out. And quite honestly, no, administration was not prepared for what happened. I don't think they even had in their mind to have a plan of action of what we're gonna do if it hits the building. Unfortunately for me, at the beginning, when it started, I myself got sick. After one of my veterans passed away. And that day when I went home, I ended up having 100.4 fever, and I didn't think anything of it, because to me, I wasn't in contact with the person that had it. But, needless to say, to me, it was already on our floor. And by the next day, I wasn't even functional, that I had to call out, and they had to call me back and they told me, you sound like you have all the symptoms of what this is, and you need to get yourself tested. So it was, you know, kind of what we went through those first couple of weeks was, you know, looking at it now, you know, there was a lot of warning flags. It was scary when I was sick, and it just sounded nothing but devastating through what my coworkers went, because as I was out, they were all texting me and telling me what was happening. You know, this veteran has it, this employee has it, and it just sounded like, you know, everybody was just falling down, you know, not one at a time, you know, 5, 10 at a time. So it was,
what you're describing, it really strikes me that, you know, I feel like at the Soldiers Home, it was a more extreme example, but like all along the way, it seems like different sets of public officials had different kinds of aha moments where they switched from like having no idea that this was something to be worried about to something that that we really need to get in gear on. Now, for the governor, he actually like thinks on this critical moment in the early part of March, he left on vacation. Neil or Evan, do we have any insight onto Baker's state of mind, and like at what point did he understand that this was something serious, and why did it take that extra time for it to come to him?
Yeah, I think, Steve, that I think it's pretty clear that once the governor was in Utah over that weekend, so this was Friday, March 6th, at the end of that first week, when, as Evan pointed out, we're seeing this accretion of really troubling signs coming out of the Berkshires. And we learned from the Department of Public Health that as soon as Dr. Calico was approved for the testing of Rick Bua, this first patient of the suspected community spread, as soon as that approval happened, we know that it went up a couple of levels at DPH and alarm bells went off. So it wasn't until Saturday that the positive came back, but between Thursday when that approval finally happened, you know, again, two tries too late, but it finally happened. Somewhere between that and Saturday when the result came back and we said, well, we have presumptive community spread right now, they knew there. As I said, we saw other institutions really start to move in that first week. There had been some hope that people thought, well, maybe this is like SARS, which, you know, didn't really, people are worried it was going to come here, but it didn't really come here. That maybe this will stay contained in Asia. I think by February, people realized that that was not going to be the case, but there was still some sort of lingering wishful thinking, maybe that it was still going to be happening to the points that Michael pointed out. I think anyone who was watching this closely was realizing that wishful thinking was past due at that point by the end of February. But by early March, we started to see again. Remember the big seeding event, the super spreader event in our area was the Biogen conference, which was the 26th of February. So the previous week, the last week in February. And that was a Wednesday and a Thursday. And then into that weekend, people started getting sick. And then by Monday night, Biogen starts notifying people, not the public, but their own employees. And then Tuesday, when Dr. Calico was first seeing Rick Bua, Biogen is notifying the Department of Public Health. So you have these two fronts on this war as we came to see it, the Eastern Front and the Western Front, and those are coming into view. And so by the end of that first week in March, that Friday with that press conference that the governor and the mayor and the Secretary of Health and Human Services, Mary Lou Sutters, sort of dismissed the idea when there was a reporter who asked at that press conference, aren't you worried about community spread? Isn't it all but inevitable now? And Secretary Sutters waved it off and said no, and sort of made the point that Evan made earlier that we can still track people. We know where people came from on this, but clearly the ground had shifted, but the public rhetoric had not. And we don't know how long it took for the reckoning to happen on the public officials' point of view, but those were very costly delays. not only for the movement on the state acting on this, but for the signals it was sending to everyone else. And of course, again, the reality we're all dealing with, the White House was for several months downplaying this, any risk of this, and muzzling any other officials in the federal government who were trying to raise the alarms on this. So there was a very confused signaling coming from Washington. But at that point, the state could have, and as we pointed out in the article, several states did. You know, on the West Coast, the state of Washington, the state of California, in many ways should have been much worse than we were, given where it happened earlier and given the population size, certainly in California. And their ultimate cases were a fraction of what they happened here. There's lots of potentially confounding factors in that, but we do know those state apparatuses responded more quickly and took this more seriously early on. Mm-hmm. And once the governor came back from vacation, he's been kind of locked in, and his team have been fairly locked in and trying to marshal the forces and working around the clock on that. But the cruel math of a pandemic that we came to understand is that only matters so much. Once you lose control of it, you're playing catch up, and it's very hard to do that. But there is this period before you lose control of it where you can kind of contain it. And that's what we lost in this case.
We have a question from someone in the audience. Sydney segues with this a little bit, and maybe this is for you, Michael. On the question of testing, it feels opaque to a lot of us and a little confounding. Why was testing so restrictive? And like, there's a whole infrastructure behind, like, DPH had certain guidelines that it followed from the federal government. Can you help us understand the rules and or the process for testing being as restrictive as it was, and what happened in this particular case?
Yeah, I think it's one of the big lessons that we can learn from this pandemic for the next time. And that's that when the CDC back in January declared this a public health emergency, there was a simultaneous effect of that, which was that there was put in place a need for what now a lot of people have recognized as these three letters, EUA, and this is emergency use authorization. And so I won't get into too many details here, but essentially it works that the idea is that when a new virus might be upon us, the relative costs of having a false result can be grave. If you have a false positive, then you might stir unnecessary panic. And if you have a false negative, you may end up with unnecessary excess transmission. So one of the ideas behind the public health emergency and the FDA putting in place a requirement for an EUA approval, emergency use authorized test to be performed to do any testing at all, is really to kind of safeguard from a little bit from what we saw with serology recently, which was we had an initial flurry of bad serology tests that turned out to be inaccurate. So, so there were EUAs put in place with the idea that it would protect the public from poor quality tests coming about, where all of a sudden the CDC and the FDA kind of take control over what tests are being produced in the private market so that they can vet them before they get rolled out to the community. That's the idea. That can potentially work, for example, with a virus that moves slowly. But for a virus like this, where it moves very fast, adding any barriers between a hospital being able to develop their own test and test their own patients, when you start adding those barriers and you make people go through the federal system in order to be able to test your own patients, that slows everything down to a snail's pace. Now there were just, so I think that the idea comes from a good place, which is to have a quality control over a test that no manufacturer has yet built because it's a novel virus. But the end result here is that we found that as laboratory directors and as people and as physicians, we actually had no capacity to test. And I recall at some point in early February calling up one of the infection control folks at our hospital. And, you know, I was so livid. And I said, you know, what happens if we just break all the FDA's rules? Like, what are the consequences to that? Because we have to get a test for our patients. How can we be expected to run a hospital and protect our staff and our patients from this virus if we can't look for it? And it was, I can't imagine that I'm the only one. I think it was just one of the most extraordinarily frustrating periods of time. And so the red tape was there for a reason, but we need to learn that there are times when the best thing that they could have done is they could have given the public a recipe, by public, I mean laboratories around the country, a very clear and concise recipe of how to produce a test. And there's a lot of molecular laboratories that know how to make this test on their own. It's not a hard thing to do. It's a hard thing to scale. And that was the big problem. Because it's a hard thing to scale
means to make a lot of them.
To make a lot of them and to do it in a lot of places. So because it's hard to process a lot of the samples in one spot, you really need to distribute it out to as many labs as you can. And they did the exact opposite. They said, we want every test to come through the CDC. The CDC can't handle the country's tests. And then they opened it up to the state labs. The state labs, as good as some of them are, they're not built to be high capacity laboratories. So a state laboratory can't be expected to take on millions and millions of people's tests. And so but that was the expectation at the early parts. And I think that it was driven, unfortunately, there was just this lackadaisical response that came from the White House. And I think it came from the federal government, and it left governors, it left policymakers across the country really handcuffed and a little bit tied down to not knowing, you know, should they take this extraordinary step to either close things down, you know, or to sort of go against FDA and start rolling out tests, you know, whatever any movement that they had was going to be extraordinary. And without the backing of the federal government to say this is needed, I have a lot of compassion for, there were a lot of blunders early on by many people in policymaking decisions. But at the end of the day, I think it was driven, all of the delays could have been mitigated if there was a clear message from the federal government saying this risk is real. And they had all the information they needed to know just how real the risk was.
Yeah. We're getting a lot of questions on the person we called Patient Zero out in the Berkshires. How could there be community transmission out there? Do we have any idea? Is there any speculation about how the virus got there, presumably sooner than anyone expected it to?
You know, there is speculation. I mean, so I spoke with the public health nurse that actually did the contact tracing on Rick, on a lot of the other people who were infected very early. And they were actually she was never able to trace it back further than Rick. But of course, there was someone who was sick, who was moving around the Berkshires and giving it to other people, you know, with the caveat that we'll never know exactly where Rick got the virus, but the sort of aha moment for Dr. Kaliko that sort of prompted the state to allow her to test Rick was when Rick's wife told Dr. Kaliko, you know, 2 of our friends are at the hospital and they have the same symptoms, and they were all at the same basketball game together a few weeks back. And so it was sort of that moment where Dr. Kaliko realized these cases must be connected. And that is sort of the moment that you sort of see light dawning that this is indeed likely community spread. So where that, whoever gave it to these people at this basketball game, that person is, you know, lost to the sands of time. We don't know, and they may not know. They may have been asymptomatic. The public health nurse that did the contact tracing told me that when she was sort of talking to Rick, and realizing that it must have been this basketball game in Western Mass, she just thought, you know, somebody just must have coughed in the stands, and who would notice that in February? I'm sure we were coughing in different places in February. So, you know, the Berkshires seems on its face to be an unlikely place, but then you remember that it's right next to New York. A lot of people have second homes in New York. As I was doing reporting out in the Berkshires, I was talking to local officials who were sort of frustrated that, you know, you would drive through areas full of second homes and see New York license plates here, there, and everywhere, because people from New York were leaving New York, where the virus was really raging, and coming to the Berkshires to get away. But what are they bringing with them? And so the public health nurse that I was speaking with, who is sort of in charge of all the contact tracing, said that, you know, people from New York City would just, you know, let her know, or let their public health department know in the Berkshires, like, hey, you know, we tested positive in New York City, so we came here. We're just giving you a heads up that we're here. That is an unusually conscientious thing to do. And I think there's no way to tell how many people tested positive in New York City and left for the Berkshires. You know, that is the fact that it is secluded and quiet and spaced out makes it seem like, how could coronavirus ever get there? But the fact that it is secluded and quiet and spaced out makes it perfect for coronavirus, because if you're fleeing coronavirus and you don't know you're carrying it with you, that's where you go. You have a second house there. You know, I spoke to a man in Vermont, right over the border, 10 minutes away from where Rick lives, who was one of the early cases in Vermont. And this is a guy who lives in a town so small it does not have a stoplight. If they want, you know, to get a cup of coffee, they have to go across the border into North Adams and get a cup of coffee in North Adams. So yeah, you think maybe there's no way that coronavirus could go there either. But if every time you need anything, you have to leave your little town, then you also have to go back to your little town and bring whatever it is that you picked up back with you. So I think, you know, Charlie Baker at one point mentioned that he thought, this was at a press conference, that he thought that the community spread that we detected in the Berkshires came from New York. That is probably the most popular theory that I've heard from people. But I think it's impossible to know. And the same public health nurse that did the contact tracing for Rick said that she had been seeing just here and there over the winter cases of unexplained pneumonia, or people coming in who looked like they must have flu, but they didn't test positive for flu. So they would be sent away with you know, some medications, but they'd come back because it didn't work, and then they'd have pneumonia, and then the pneumonia wouldn't respond to the antibiotics. And so those things are, is that a bad winter? Is that early signs of coronavirus? Like, we just won't know because there wasn't testing.
I don't know if this travels old ground, but we're also getting questions about whether in reporting the story, you guys found good explanations for why the agencies that were, and I guess apart from the federal messaging and so forth, why the agencies that are in charge of public health in Massachusetts and that have these reputations for excellence, well-earned ones it would seem, were so unprepared in this particular case?
I can take a crack at that. I think in some ways it's impossible to segregate that answer from the federal response because they were told, you know, they have to follow the CDC requirements about testing, and that compounded things. They were told initially.
So that's true that the state, like when Rick Bua's doctor called from the Berkshires and said, I want to test this guy, they have a set of restrictions based who they can test. And that comes directly from the federal government, is that right?
That's right, but one place of accountability I think that falls on the state is the CDC, after realizing how much they had screwed up, started moving that week, that first week in March, and started on that Wednesday saying we're going to turn this over from this very strict list of requirements before you can authorize a test. And remember, you know, if someone shows up in an emergency room, that doctor has to call the CDC, the state hotline. The state hotline has to report to the CDC and kind of if there's going to be any departure from that. So there's this whole unnecessary, to the point Michael made, chain that made things more bureaucratic at a time it should have been more streamlined. But I will say on the state part, and we pressed the state for this and they didn't have good answers for, it was clear as the CDC was moving under pressure to turn that decision over to clinician discretion, meaning if you're the Dr. Kaliko and you're seeing the what looks like a very troubling thing, you should be able to make that decision. The CDC that first week in March made that shift to clinician discretion, and the state was still, for several days, quoting off the old script, which was CDC doesn't say that. You didn't travel, why are we even talking? And so that, I think, there was some communication breakdown on that. We pointed out, there was a hearing at the State House that Michael testified at, and the Commissioner of Public Health was there and was talking about the old script, and the state senator was just handed this thing from an aide saying, they just posted a story that the CDC has changed this, and clearly there was a communication breakdown. So the again, where everyone needed to be at this point moving with urgency, they weren't. They were moving kind of with those bureaucratic hiccups that wouldn't be so costly if this weren't a pandemic.
Is there any...
Steve, I have to agree, with Neil and Michael, that because of these, agencies that we looked upon to as to, where can we go and what can we do? I think, from our state home, we were also looking to the CDC and, from, the Sutter's office. And there was, again, there was a strict guideline as to what veteran, could get tested and if you were symptomatic or not. And I think if they had let those things, able to test earlier, we could have gotten a lot, more results faster. And I think what had happened to at the home wouldn't have happened, because there was all sorts of little symptoms, but because they weren't showing, 2 or 3 to the guidelines of the CDC, nobody could be tested. And once we did find out that somebody was positive, none of the staff was allowed to be tested until we showed symptoms. So of course it just made things even worse. These public, things that we look to, have to realize that it's the public people that look up to them to say, hey, can we test, regardless, because somehow if we find out sooner or quicker, this is, how we're going to be able to prevent, or at least, help out in what happened in our home. I think if we had been able to do a lot of testing quicker and sooner, I don't think the devastation would have been as bad as it has been.
And just to piggyback on that quickly, what you did see in this case, when the deaths really started to spread, is this move that the hospitals we talked about that make Boston so world famous did kind of snap into action on this. The institutions weren't able to. They didn't have the capacity to do that. Joe obviously is talking about where it was at its worst, the failures from the state, the failures on the state oversight. There's no better and more tragic and painful example than the failures that put people like Joe and the dedicated staff there on the front lines in such a horrible position. But if you look around the state, that was in our article, because we can only capture so many things, that became our kind of proxy for institutions. But if you look at around the state, the nursing homes around the state, really, they did not, because of state oversight or the capacity that those institutions had, did not have the ability that the academic medical centers had to snap to attention and really start to swarm the end zone here with all the resources you needed. And that's really where we see the deaths accumulate.
Is there any reason to think that these lessons will be absorbed and learned?
I think some of them will. I mean, I think all of this discussion has to be, the whole response, you asked the question before, you know, why didn't things snap into place? You know, this is unprecedented for the world. The US has for its entire existence, almost, I mean, there's been a few epidemics and pandemics that have existed, but the last one that really, you know, spread like this was over 100 years ago now. I think that that we've been able to rest on our laurels a lot. And in some ways we're geographically separated from the rest of the world. You know, we have oceans on either side of us. We're of course connected north and south, but we have a lot more buffer in that way from other things. And now with global transport being much greater than it was just 20 years ago, we are now having to no longer rest on our laurels and just assume that these things won't come to our doorstep. But I think that all of this has, like, this is unprecedented. There were no mechanisms in place. Now, I think we should be talking about why that, you know, different conversations, why were there no mechanisms in place? The whole field of infectious disease epidemiology exists because we know that this is a real threat. But I think that, like, when we're talking about the speed at which governments acted, a lot of the policymakers were just, I don't think people understood. Most people are not epidemiologists. They didn't understand how quickly things can get out of control. Most people make decisions based on what they're seeing and not some mathematical model that tells them what they're most likely going to see. And that's a really, you know, most humans just aren't good at acting very quickly, especially within the big structures that we've created. So I think the one thing that I very much hope that we learn from this as a society and as a governmental structure is that there are times when we just need to act fast. And in this case, we don't only need to act fast when it's on our doorstep, but we better start building the infrastructure as a state and as a country to not have this happen again.
And if there's, you know, it seems like by many accounts, this virus will be with us for a while in some form or other. Very quickly, what do you think the prospects are of coping with it on a public health level?
I think we have a long way to go. What we're learning more and more is that there's really no place on Earth yet that has developed sufficient immunity to not have increased transmission again. I'm very concerned that, especially in the Northern Hemisphere where we're entering the summer right now, we're going to be, our response now and as we open up, I think that we might have this weird interaction with weather where transmission might actually be slightly less because of the summer months. And I'm particularly concerned that people and decision makers are going to think that this is the new normal, that this is okay, that we got through the worst of it. But the reality is coronaviruses usually spike in October every year. They go up and then they stay up from October through about April or so, and then they really start to trail off. So we only saw about 2 months of that with this epidemic. Now imagine if we didn't even see the peak in terms of when we usually have the most coronavirus transmission and from year to year for the seasonal coronaviruses. So I think we're going to get into the fall and I am very concerned that there will be massive outbreaks again. There's going to be continued outbreaks throughout the summer as well. I don't think there's any question about that. But I'm very concerned that the fall and the winter are going to hit, and we will be reinventing or seeing everything we just saw, but potentially much worse. And I think, you know, when we think about how this virus entered into the United States, it was in a handful, maybe hundreds of imports from abroad. But by the time the fall comes around now, we're going to have thousands or tens of thousands of the equivalent of those imports all happening across our country. from these low grade sort of transmission chains that are happening. And that is a recipe for an explosive disaster, I think. And so I hope that we continue to improve our monitoring systems. That will be testing. It will be creating databases where we can really monitor for symptoms and using mobile apps. We have to start building this infrastructure now. And it's not for the next pandemic. This is for the next wave of this particular pandemic. And so we have to act quickly.
Joe, just by way of trying to think about wrapping up here, give us a picture of the Soldiers Home now. Things are improving, I hope.
Yeah, I think, you know, from everything that we went through, and of course, you know, all the staff, the majority of the staff that, you know, ended up getting it, a lot of us, you know, had a great recovery. The majority of our staff is back. You know, personally for myself and my unit, a lot of, you know, the veterans that, you know, had it when I came back and weren't looking like they were going to make it are actually thriving now. They're back to what we call their baseline. You know, so, you know, they're eating again, they're interacting, they're being mobile. So, I mean, it's looking positive, and I've traveled through the different units as well. And it looks like, you know, they're making a good recovery. So I have hope that, you know, that eventually, you know, we will get a hold of this, you know, as we continue to practice, you know, social distancing, you know, good hygiene, and, you know, but I still worry for the people that didn't get it. You know, there's still an amount of people out there that I worry for, and even in our building, there's people that never got it, and I worry for them. But so far, you know, for our veterans, a lot of them are making a good recovery, and it's good to see them, you know, be up and up and about again. You know, so it's looking, you know, hopefully we go to, you know, back to our normal of what we had at the home for them, you know, with all the activities and the visitors, you know, and this will be something that we will, you know, I've certainly learned a lesson from, you know, and hopefully the administration and the state, you know, people have learned something too, you know, how to better react to something, you know, not just for nursing homes, but for, you know, everybody in the state.
Joe, thank you so much for being with us. Really appreciate it. Michael, your perspective is fantastic and very illuminating. Thank you. And Evan and Neil, what an amazing story you guys did. And we hope that will translate to, you know, a better public response in the future. Thanks to you guys, and thanks to everyone who joined us this afternoon.
Thank you.
Thank you, Steve.
Thank you.
Yeah.